a lot of great insights into treating the younger demographic of our patients. So, yeah, look forward to hearing everything you have to say, Hayley. And yeah,
Awesome.
thanks very much for jumping on.
No worries. Thanks for having me. Matilda's here.
There you go.
A little bit of background. Thank you for that, Andrew. I have been at the university for honestly far too long, probably at this point in time, and have been always heavily involved in teaching the third year content, which is the pediatric theory. And then going into fourth year, our students have a designated PEDS clinic every week. And so as a tutor on that clinic, I have had my own practice as well. And just given the way that it works, I saw a lot of PEDS patients in my private clinic as well. So without further ado, I'll just share my screen and we'll get started here. And just get rid of these faces once the screen thing goes up. Just put us down so you don't see double. All right. So the aim of today is that I hope you'll just take yourself off mute at any time you have anything you want to talk about or to ask a question, because I think the interaction is the best part. So I can't see your faces, so I always find that challenging because I don't know if you're finding it boring or you're excited or if you're paying attention. So at any time, just take yourself off mute and let's have a chat about something. Ask a question, stop me at any time. So this is what I was asked to talk about today. Thank you, Andrew. It was great to have like a nice set theme for today. So our main goal for this session is to update the team on subjective and objective questions and tests for children. We'll also explore how these relate to creating treatment pathways, the traffic light concept, and when we are referring patients. So from that, I took it to mean that we're going to cover these main areas today. We're just going to have a little go over some subjective questions, objective tests, those treatment pathways, and also the traffic light system. All right, so let's kick in first. So subjective questions. First of all, question for you guys, anyone jump off mute. What template are we using when we're guiding ourselves in a paediatric consult, and in particular around subjective questions? Anybody? Is anybody using a particular template?
I can't remember the name of the template, but we've integrated it into our PEDS initial treatment note.
Yes.
I just can't remember the name.
Excellent. So you have a nice
It's the
clinical, the Gallup. Beautiful.
Yeah, that's the one.
So ideally, we're all working from the Gallup. And if you went through La Trobe, that's how you would have been taught. If you went through UniSA, you're using the Gallup. I assume similar in Queensland. So the Gallup obviously has been around for a number of years now. It wasn't around when I studied. And Andrew, I reckon, might have been a bit shy of yourself as well.
Yeah, I don't reckon it was.
Yeah, okay. So the Gallup is what we use now as a guidance tool that was put together through a Delphi study looking at questioning a whole heap of experts and coming together and putting together the Gallup to guide clinicians. It's for physios and pods. So if we start with that in mind, let's go to some subjective questions. Oh, hang on, sorry, my little tabs come out the way. There we go. And I am going to ask you to contribute to this. So just start firing at me some of the subjective questions that you want to know in the start of your PEDS consult. Hit me with some.
Birth weight.
Absolutely. Thank you. Oh, you'll see how bad my spelling is as well as we go through this.
Hitting the right milestones at a right times.
Yep. So we've got lots of milestones to discuss, and we do actually have a slide coming up on that as well. So milestones will fit in here.
Birth.
Sorry?
Type of birth.
Absolutely. And what have we got in terms of type of birth?
Natural, C-section, emergency, non-emergency.
Absolutely. And this is not me picking on you by any means. We are trying to make a concerted effort when we are teaching this to our undergrads that we've dropped the term natural. because it actually can hold a lot of traumatic suggestion to a lot of women who think that having a C-section isn't natural, or it wasn't right, or it wasn't part of their birthing plan. So we are teaching the students, and they are slightly horrified the first day I use it in third year, but we do talk about a vaginal birth or a cesarean birth, just to move forward in case you have a mother who has had quite an experience in the birthing area. So we have vaginal, we have cesarean, and of course that splits off into, was it an emergency cesarean or was it a planned? And why might we want to know that?
If they're planned, then they'll have more structure in place around the birth, whereas if it's emergency, there's likely a complication involved.
Absolutely. And the other thing to know about a planned cesarean, what could that maybe mean as well that's important to us?
Other factors that are meaning the birth needed to be sooner.
Absolutely. So that could have been around restricted growth. It could mean that it was a very big baby. And what's another important reason that people have a planned cesarean?
Like preeclampsia?
Yep, absolutely. That's definitely a very important complication. Something else about the way that the baby's presenting that could end in a cesarean.
Breech or not?
Breech, yes. So breech position. So why are we talking about breech positions? Why do we want to know about what position the baby's in?
Was breathing complications during the birth?
Yep, we've got breathing complications.
We'll know if their foot's getting squashed or not.
In the breech?
Yeah.
Yeah, so really importantly, the one thing that I want your little antennas to go off about when you're asking about the position that the baby was in is hips. So hands down, hips become the main thread that you're going to follow through with if they're in a breech position. So very few babies will now be birthed in a breech position because of the serious complications that can occur, particularly for the mother, but also for the hips of the baby. So if in the final trimester, a baby has not rotated to be head down, ready to go, and they're still bum down or feet down, often they will try to turn the baby, and that can be done several ways, but it doesn't always work. Often the baby will turn part way and then rotate back again. So often a planned cesarean will be chosen. So it's very unusual that you'll find a baby that has actually been birthed in a breech position, unless it was, you know, they got caught out there in the car, something terribly has gone wrong and the baby's been born early without any intervention. So if we're talking about breech position, what are the different breech positions that we discuss, the different categories? So in layman's terms, we can have bum first, which is a frank breech position, which means that as they're coming through the birth canal, they have both legs up around their torso and their feet are up around their ears. And the reason that that is so problematic is because as they're coming through the birthing canal, it puts pressure down on their hips and we can get hip dysplasia as a result. There's also footling delivery as well, where they come out foot first. And in that position, they might have one leg that's stuck up and one leg that's stuck down, which is also going to have implications for their hip position at birth as well. Oh. So sorry, I think my headphones just timed out. Are you still hearing me there okay?
Yep.
Okay, so sorry, you might get a little bit of background noise. I'm very sorry. So we've got our breech position, complications for our hips, and someone did mention about the position of the foot. So there is a time when the foot becomes a little bit more implicated, and that is around a condition called oligohydramnios. So has anyone got any ideas what that one is related to?
No.
So oligohydramnios is a really long word just to mean that there's not enough fluid inside the uterus during the pregnancy. So because there's a lack of fluid, there's a lot more pressure on the baby as they're developing. And in particular, it can be a really good risk factor for metatarsus adductus development, hip dysplasia, and also one for the physios where we get torticollis, where the head's actually stuck tilted to one side and they get shortening of the muscles. So oligohydramnios might be one of the complications that you hear about during the pregnancy as well. All right, so if we're talking about breathing complications, what is one of the risk factors if there have been breathing complications for a baby at birth? What might be you wary of?
EP.
Absolutely. So we start to wonder, has there already been a diagnosis, or could that be something that you're seeing in your objective assessment that ties back to that complication? All right, what have we forgotten here in our subjective? Where are we up to? There's a couple more here.
Just in general, I might ask about their APGAR score, and if they don't know what that is, I'll just ask, did they need to perform any sort of first aid, or, were there breathing complications? And then they remember, and then they'll tell you what it is.
And especially if you have, I'll just say not the mum present or whoever birthed the child, sometimes we can forget what the APGARs are if we were a caretaker just present. So when is the APGAR taken?
Is it straight away?
Yep, so within 1 minute, and then when is it done again?
Is it like 5 or 6 minutes? It's not too long after the first.
Yep. And ideally, what should we see in an APGAR score, particularly if it was low at 1 minute?
Low, you said?
Yeah.
The baby won't be crying, the color of the baby. Trying to think of the other ones now. Can't remember, sorry.
Yeah, that's all right. So if it was particularly low at the 1 minute, so if say it was a 2 out of 9, which would mean that resuscitation was required and oxygen, etc., what we should see at 5 minutes is that their score has improved. So even if someone had a fairly average 1 minute APGAR, obviously all systems, all the staff are working hard to make sure at 5 minutes the oxygen levels have increased, etc., etc. If someone often doesn't remember the APGAR, I tend to take that as there probably wasn't a problem. Most people remember if there was a problem, because a baby coming out not breathing and watching the crash cart come in and all that trauma, they remember that. So if they tend not to remember it, often it's because something didn't go terribly wrong, which is good. And there's another one in this subjective area. What are we missing?
Gestation and how many weeks they were born.
Absolutely. We forgot about that one. And I was thinking one more.
NICU.
Thank you. Yeah. So did they spend any time in any of the areas of the hospital? Here in Adelaide, we call it SCBU, which is SCBU. They're often not in humidity cribs, but they're still being monitored in an area. Obviously, NICU, there's a lot more going on. So if they've spent a significant time in hospital and we want to know why and what was it for and how long till they were released back to the room and how long until they went home, were they sent home with oxygen devices, etc. What else are you asking in your subjective that might not be part of that first box of the Gallup, which we'll have a look at in a minute? Where else do we go in subjective?
Was there one about, was there any other health professionals involved in the birth or post-birth?
Absolutely. And this one comes in nicely when you're talking around this stuff. You'll often hear, or around the APGAR, that there was a lot going on for them. Absolutely. What else do you like to ask your kids?
About their pain?
Yay. Pain. What's going on? And what do you in your team use for your like when you're talking about pain? Do you have any particular acronyms you use or structure that you follow?
It's probably more the visual analog.
Yep.
Scale. We've got that in the rooms that they can point to.
Yeah. Do you use any NOLDCAT or anything like that to guide your questioning?
Not sure if we do. No.
Okay, we can have a look at that as well.
Yeah.
There's a lot of them. I know at undergrad at UniSA we talk about NOLDCAT, so it talks about the type of pain or the injury. So we've got the nature of the injury, the onset, the amelioration, etc., etc. So questions around pain and location. All right, so let's just flick back here to our Gallup so we can feel like we've covered everything off. And absolutely, so we've talked about gestation, the type of birth, were they in a breech position, complications, other health professionals we've been through. Oh, we didn't talk about instrumentation. So sometimes it's important to understand how the delivery occurred, especially if the baby was stuck for a significant amount of time. That can lead to some MSK concerns or breathing concerns. So we've got forceps, which you won't hear much about these days, but ventouse, does everyone feel comfortable with which one that one is? If we talk about ventouse delivery. If not, that's the vacuum. Like, yeah, the suck, it attaches to the baby's head and applies suction to help progress them through the birth canal. All right. So if we flick back here, subjective questioning's going well at the start. And you're all clinicians. You all know that if you start to get a little bit of, you hear about some complications, you're asking, what were they? What other health professionals were involved? Has that translated to today? Who are you seeing still? So you know to follow these threads out as you keep going. So let's just jump to what are some of the problematic ones that we want to really catch in this subjective history. So we refer to them most likely as red flags. Let's start talking about some of the red flags. What are some of the ones you know off the top of your head? Any that you can think of? If we talk about
underweight.
Yeah, so what is that cutoff for the birth weight that we start to wonder, has everything been okay?
Is it 2.5 kilos or 2 kilos?
Beautiful. So 2,500 grams. When does that one fall through a little bit for some people, that it's not such a red flag? There are sometimes in some particular races that one does fall apart a bit. In a lot of Asian cultures, we can have very small babies and it's very normal. So sometimes because of genetic, it could also be just family history as well. All babies have been small, but very okay. But 2,500 grams is that cutoff, which might suggest they've been a premature birth. What else have we got in that red flags?
Gestation under 37 weeks.
Beautiful. So 37 weeks is our cutoff where we start to talk about being premature. What is happening really importantly at week 36 to 37 that can indicate how well a baby is thriving?
The lungs, isn't it?
Yes. So we start to, by 36 weeks, even though that is under 37, they often assume the baby's going to probably still be okay because the lung development has occurred to such a point that they should be able to breathe on their own. The other reflex that kicks in at 36 weeks is sucking reflex. So sometimes if children are born around that 36 to 37, they might not have their sucking reflex happening and might need a little bit of intervention. But 37 weeks is that cutoff that we start to, babies will be talked about being premature. Any other red flags?
Some reflex, absence of reflexes.
Absolutely. And as we get to that objective testing, we'll definitely kick into our neurology. But particularly in those APGAR scores, if there's absence of reflexes straight away, that would be a red flag.
If they've been in NICU, it's generally a red flag or something just to be mindful of if they have some odd presentations.
Absolutely. And definitely, as you would, you're going to follow through that unit of inquiry as to why, what happened, what interventions were actually occurring. So if we have a look, oh God, let's go here. It's supposed to come on when I click. Oh, what am I doing? Hang on. Oh, for goodness sake. My animation's letting me down.
Maybe if you click in the middle of the screen.
You reckon?
Yeah, maybe.
Because it's got an arrow down. Ah, there we go. Thank you.
Oh,
all right.
good.
So we talked about, we've got gestation, we've got the birth weight, sometimes the non-spontaneous, that's spelt wrong, sorry, non-spontaneous labour. So if a labour has had to be brought on early in particular because there's something going wrong with the baby, you want to know why. Any of those assisted deliveries that we talked about, ventouse, etc., multiple births. So from our perspective as a pod, probably the things that are going to make more sense to us or that we're more interested in is when there's been multiple births, so twins, triplets, or more babies. It really comes down to cramming. So obviously they're going to be smaller and things like that, but due to the cramped conditions, are we leading into any of the MSK things that we see? Hips, hands down, would be implicated in some of those bubbers, and metatarsus adductus and things like this start to become more pronounced. The breech position, always asking about that breech position. And something I didn't mention when we talked about it just before is that even when they haven't been birthed in a breech position, purely being bum down instead of head down in the last trimester when they're at their biggest, fattest, and in the tightest position that they have been the whole pregnancy, that in itself is putting abnormal pressure on their hips when it shouldn't be in that position. So purely just being in that breech position in the last trimester is still one of those red flags we want to follow through with and check the hip history. On that, when do hips get checked in babies?
Is it as part of the initial assessment?
Absolutely. They get checked straight away. And then when do they get checked next?
I think from my experience, it was 2.
2 months?
I was going to say 2 years.
Yep, so they might be there, but at 6 weeks, at that first CAFS appointment or first nursing appointment that all children are actually scheduled for, the hips are checked then as well. So at that 6-week mark, hips need to be cleared or followed through for further investigation. It is quite common for there to be something that feels a little bit different about the hips in terms of maybe a bit of laxity or hip dysplasia. They'll first of all be sent for ultrasound. If the ultrasound is cleared, happy days. If ultrasound is not cleared, they might follow through with X-ray and back to the paediatrician, obviously, as well. So if there has been hip pathology concerns, once again, parents tend to remember this because they went through that cycle of going through all these appointments. So we do want to know about that. Interventions at birth, which we all know there's lots of different ones, and postnatal complications. All right. So once we've been hitting our subjective, we are heading into, I guess this is where the form gets a bit confusing because some of these are subjectives in that you might be asking them, but obviously some of them are objective if you're observing them occurring today. So let's head through our age of skill acquisition and also down into some of these down here as well. That's where we are in this Gallup form at the moment. So if we jump back in here, our objective tests, you might be observing these as I mentioned, but obviously to understand what's abnormal, we really need to remember what is normal as well. So these are the typical, we say windows because every child develops slightly differently. We give them a window to develop these skills, but ideally if you looked at the means, you're looking at about 6 months to sitting in a ring sit, which is like that baby's doing with the legs out in front. That demonstrates that they've got good postural control, they've got good hip stability, and they're in that beautiful external hip position, which we like to see babies developing in. Then they start to move to standing with assistance. Obviously, they're not doing it on their own yet, and crawling. So what other type of crawling might you see during this era if it's not 4-point crawling, which is what we call the hands and knees crawling?
You might see the bum shuffle.
Bum shufflers. What else?
Crawling arms, like that pulling motion.
Yep, so commando crawling.
Dragon.
Yep. Have you seen those little crab crawls where they kind of tuck one leg behind them and one in front and they kind of scoot themselves along as well? What kind of things do you start thinking what's going on there if you see one of those little asymmetrical crab crawlers? What are the hips doing in that position if you did it yourself, like a half W sit? So one this way, one that way.
I think you'd be a bit concerned about maybe some dysplasia in that hip.
Yeah, and Absolutely, because it's quite abnormal for a child of this age to be in anything other than an externally rotated hip position. So the fact that one is locked into a full internal range of motion would be strange and something that you would be like, I need to check their hips today, because that could be a problem there that they're showing us. It's also a really good sign that there could be some laxity going on, because they shouldn't have that much range of motion in an internal rotated position. A heap of kids, having said this, don't actually crawl, and there's absolutely nothing wrong with that either. What do you think are some of the limitations as to why some children don't crawl? And these aren't really medical, they're just things that happen in life.
Isn't the flooring one of them?
Absolutely. Most floors in most people's houses now are really good at being cleaned, but it also means they're hard and cold. And slippery. So sometimes the flooring surfaces play the role. If you've got a little bubba heading around in their onesie and with the feet in them, they're slippery. So getting up on your hands and knees and trying that and slipping out isn't such a safe thing to try. So it could be the flooring that's problematic. What else? So we can have, particularly when they're the firstborn, they just get carried around all the time and no one puts them down. They're literally like just being handled a bit too much. They haven't had time to explore the floor on their own very much. And so some of those skills of rolling over in the prone push-up position have kind of been missed. So it could be that their skill progression and practice hasn't occurred just because they haven't had the opportunity to practice enough. And along that thread, if they're a second, third, or fourth kid, what often happens to them in a family situation?
They get put in the pram.
Absolutely. They literally keep getting put in things because logistics. There's 2 kids already on the go. They need to contain this one child. So often they get put in those activity stations, which, like the disc with all activities, and they're kind of hanging from their pelvis in those. So once again, lack of opportunity, being put in a position that is advanced to where they should be in their skills progression. So there are actually just some practical reasons as to why some kids haven't crawled, but it is important that they do learn it ideally. But some kids, 4%, won't crawl and have no issues. All right, then we move on to walking with assistance, which is also known as cruising, when you see children laterally transfer across furniture and objects. There's this study that I always remember. They put little tiny monitors, pressure monitors, inside little babies, like little shoes, and monitored how many times a day a child who is cruising, doing that lateral weight shift, how many times a day they went from side to side and shifted their weight. 1,100 times a day they performed that task. 1,100 weight shifts a day, which when you think about what they're achieving in that moment, it's bone molding. So obviously form follows function. So wherever we're putting pressure and weight, we're obviously building bone development. So if you think of what's happening at the hip at that point in time to create a really strong acetabulum and, nice deep cup for hip support, so important before they take off and walk that they've gone through that phase of cruising and practicing their weight shift. And often if children are missing these steps because they haven't walked yet, physios and other practitioners will take them right back to this skill set because it's so important for so many reasons. We get standing alone, obviously starts to occur after that, and then walking by about 12 months. So let's go through the one that we probably remember. At what point is it a red flag if they're not walking yet? What is that upper limit that we start to think that's a problem?
From my understanding, if it's over, like if they're by 18 months, if they're walking, like it's not too much of a worry. But if they're approaching that 2 years and they're not walking, that's when we would be really concerned.
Definitely be by 2 years. And in fact, it's actually by 20 months. So 20 months is considered that upper limit, where if walking is not occurring, it doesn't mean that there's necessarily something disastrously wrong, but we need to start working out why. because that is the upper limit before we start to think what's going on here. There are actually points in all of these skill sets that we start to hit that upper limit. For sitting, it's by 10 months. If a child's unable to sit unassisted by 10 months, needs to be followed through. 12 months standing and practicing with assistance. 14 months for that lateral weight bearing and the cruising. We start to wonder why. So we do need to keep in mind these upper limits when we are taking our history. It doesn't mean, oh my God, I've got to refer you straight away. We would have done a thorough assessment with our Gallup and we can start to work out perhaps why, or what are some of the reasons why they might not be doing some of these skills yet. All right, so as we're here, the one area that we haven't touched on yet in the Gallup is this little area here. So we've done some of this age of skill acquisition, but also these areas here. So if we talk about some of these skills here, I'm going to put it to you guys. What are we? One? Yep. When would you start to see skipping emerge in a young child? About what age are you hoping to see skipping emerge?
Like 3 or 4?
So even a little bit later, definitely if they're skipping at 3 or 4, they are quite advanced. About 5 to 6, skipping starts to happen. Skipping's a funny one because some kids just have never practiced it. So it's just something they've never seen. It might be something they've never partaken in at school, where you might have some kids that have done a lot of dance and things like that. So skipping's something that naturally evolves from there. But about that sort of year 1 at school, we should be seeing children be able to, if they've never seen it before, watch you do it and then replicate. So skipping actually is quite a coordinated effort. And to be able to skip, you need to be able to stand on one foot, or at least for a small amount of time. So if we're thinking that way, when do we start to see hopping emerge?
Would that be more about that time, that 3 to 4?
Yeah, exactly. So about the age of 4. So I mean, I see my undergrad students do it all the time. They might have like a 3-year-old in them. They're like, oh my God, they can't skip. And we've got to go back to what should we expect from children? So hopping's about 4. And that's a tricky thing for kids to learn. If you've ever done this down the gate, down your gait assessment area, hopping is really challenging. But about the age of 4, we should be definitely exploring it. If we go back from there, double foot jumping, when does that start to emerge in children?
I think it's about 3.
So even earlier, yep. So 2 1/4 actually is about the time that we should see both feet leaving the ground. Kids, you know, when you're first getting them to practice jumping, they sort of do a gallop, and then it should progress to both feet elevating from the ground, about 2 1/4, or at least they're starting to explore it and do it themselves. Running, obviously post walking, and squatting. When should we see squatting happening?
Is it like 18 months to about 2?
Yeah, so ideally they should be squatting before they walk. So if you can't squat, it means, okay, so you're a toddler and you're just under 1, you're about 1 year old, and you're attempting to stand up. Some kids will go straight from that cruise position on furniture and then sort of just step out into the middle of a space and stand for a while, and then they usually drop onto their bum. But if you are going to be able to walk or stand on your own, you actually have to be able to squat, because what happens if you're standing up and you need to hit the ground? Ideally, it's far safer if you squat to the ground than just topple to the ground. So squatting is this weird one that kids should be investigating before they are likely to independently walk. So humans, everything we do is about self-preservation. And when you look at 1-year-olds in particular, under 2, their heads are huge and they're heavy. It's the biggest part of their body, and it's way up top when they're standing. So our center of gravity is about at our belly button. Theirs is way higher because their head makes up 1/3 of their height. Where when I stand up, I hope not, I hope it doesn't, but my head is not 1/3 of my height. You know, it's what is it, 1/5 or 1/6 or whatever it is. So they have this huge heavy object way up the top and a really high center of gravity. So naturally, they will not progress to walking or standing on their own until their body has worked out how to do that safely. So ideally, they're squatting. Otherwise, there's a lot of head injuries. And being self-preservated, the body just doesn't do things like that until they know that they're in a bit more of a safe position. So squatting is something that you should be seeing when they're playing around on the ground in that cruising stage. And how do you want to see them squatting? What are some of the things you'd love to observe if you had an 11-month-old in your clinic?
External hip rotation.
Beautiful. They're in that beautiful external hip position. What are their feet and lower legs doing?
Slightly
The heels are on the ground.
Heels are on the ground. Beautiful, because they've got so much range. Absolutely. Bums out behind them. They're in a really deep squat, feet flat on the ground, tibia shaft rotated outwards as well, following the line of the knee and the foot. Really strong hip base, and they should be able to go up and down from there really easily compared to us. So you want to see a really nice strong squat. So if we just refer back to here, we'll make sure that we've, oops, sorry, down a bit. Let's have a look. So squatting, skipping, that's that year 1 child, hopping around the 4 years. Now, single leg stance, this is from papers, this is from actual presentations. So the way to remember this is at 3 years old, they should be able to start standing on 1 foot only for about 3 seconds, which isn't very long. By 5 years old, they should be able to stand on 1 foot for at least 10 seconds, which matches up here because they're starting to hop and then they're moving towards skipping. So that single leg stance position becomes far more stable for them. By about 8 years of age, we're looking at about that minimum adult range, which is 15 seconds. So I think my students tend to remember 3 = 3, double at 5 years, and 8 is the adult average of 15 seconds of single leg stance. Super easy for you to add this in if you haven't already been doing this in your practice. This is a really good one, and stop me if I'm just telling you things you know. But obviously we want to observe it in children to take baseline. But if you've then done footwear as a treatment or orthotics as a treatment, this is a beautiful one to come back to and do before and after outcome measure to show that their stability is increased and their balance is increased, because they can now stand easily for 3 seconds or 10 seconds or whatever it is they have achieved. Stair climbing, if you do have stairs in your clinic, a lot of us don't, so this one can be a hard one to measure, but if you do, kids are usually able to go step by step without needing an adult assistance by about 4 years of age. You know, when they're little, they do step onto the same riser each time, or they're using the handrail a lot. By 4, they should be able to maybe mimic stepping upstairs. All right. Any questions on any of those observations?
When you're doing these assessments, are you just letting the kid play with some basic little instruction, or how are you generally observing these?
So good. And this is like a whole nother topic, and I love this stuff. So you've got lots of options here. So if you've got someone under 12, well, I would say 1.5 and under. Well, think of your own kids. It could even be 2 and under, depending on how they go following instructions. A lot of your consult's just going to be observation. So you're going to create a really inviting, safe space for them to be in, which again is challenging in a lot of clinics, but I feel like your clinic, you might have some space for this, where you've created a less medical looking little space. Maybe you've put a nice kid-friendly rug down, you've put some toys around. You might even have something that they can pull up onto, like like an ottoman or something really handy like that. And you're going to sit maybe one side, caregiver's going to sit on the other, and you're literally going to be taking your notes while you're observing them. In that time, you've probably watched them crawl, you've probably watched them pull up and stand, and while they're standing at the ottoman, you're madly looking at their leg and foot alignment. So it might be a lot of observation. Then if you're feeling that rapport's going really well, that's where you might move on to be able to do some hands-on assessments. But a lot of it would come from observation, especially if you think I'm not going to be able to get hands on this child today because they're quite cantankerous. It's a bad time for their sleep. They haven't eaten quite enough, or they're just not feeling like they want to leave their parent. That's where you might do hands-on assessment on the parent's lap, or you just observe the consult. Once they get beyond that, that's when I think getting really good at getting that rapport of doing a really fun gait assessment. So all my kids, when we do gait, I'm not getting them walking. The first thing we do is I set up the perimeter. Going to get you to walk from here, and I send mum or down the other end, and you're going to walk up to dad and give them a big high five. But then I just start messing it up. I'm like, I want you to run as fast as you can if it's a safe area, and then back again. Now I want you to jump on 2 feet like a kangaroo. Sometimes, obviously, I'm looking at these things for coordination and skill development. But once they've got a lot of that jumping out of their system, and you've got them walking sideways, they've done a crab walk, maybe they've showed you some of the hopping that they're attempting, then you'll get a nice walk out of them. So it just depends on your age, where the child's at for the day, how excited they are. If you've got the kid that's just bouncing off the ceiling, the best thing you can do is get out and do some good fun gait assessment before you try to get hands-on with them. Get the beans out the way first. So a little bit of both. All right. So where are we up to? We are up to the bit that we talked about in that subjective. Now, what age group are we using the Baker-Wong Faces scale here? What age is that applicable for? So when it was actually produced in the research, it was tested on 8 and under. So officially it's been validated for children 8 and under, while our pain scale, or using any type of numeric conversion, should only be kids 8 and up. Obviously, there are differences amongst perhaps intellectual development, or if you're dealing with some developmental concerns, then maybe you're always using the Baker-Wong Faces scale. But 0 to 8, well, not 0, but you know what I mean, under 8, and then 8 and up if they're starting to understand numbers.
So that's the one, like some have got tears on their eyes, and is that the one?
Yes. Could you see it just before? Sorry, just there.
I don't think we can see. We can only see your Canva.
Oh, Jesus. So sorry. Let's stop for a second. Andrew, I had no idea. Let me just flick back here. How does this one go? My God, I was referring to it. I'm so sorry. Is that better?
Yes, we can see that now.
Oh my God. I feel like I need to start again. I'm so sorry.
No. It's good because we've got this as Nigel said, we've got this we've basically added it in as a clinico thing. So I've taken it directly off this, but it doesn't have the Baker-Wong Faces in there.
So it would be something you could add in. So all I was pointing to as we're going through is just making sure we're all heading in the right direction down our form. This is where we're looking at the observation of skills. This is what I was reading from just before. I'm so sorry. That's where I was getting our numbers from. So the single leg stance, we're looking at 3 equals 3, 5 equals 10, and 8 equals that 15. You'll have that now. I'm so sorry. If we come down here, that's this one here. So we're looking at the Faces scale for 8 and under, or here, the numerical ordering when they're 8 or older. But yeah, that's your hurts a lot, doesn't hurt at all. It obviously really matters which one you refer to and how you refer to it, because obviously pain is a subjective experience. So some people don't want to look like they're crying if they're in a lot of pain. So that could put some kids off. They don't want to say, yeah, it's in so much pain that I cry because of it. So, but generally that is the one that we use. All right, let's flick back here. I'm so sorry about that. I feel really stupid. All right.
No, it's silly.
So we've got through lots of our assessments, subjective to this point, and hopefully you're feeling good. You've got it in your clinico, so you're taking a really good system there through your assessment. Now, if we talk about some of the objective tests, now obviously the Gallup is going to guide you on objective measures that you're taking, but I've just picked these ones out because I think we should think about these. Definitely Baton's score. I won't ask, does everyone know what it is? How is this part of your current objective testing in children, your Baton score?
I'll do it for some kids, but not all. Just really depends on how my subjective has gone. And then if I think it's relevant, I'll do it. But I'm not sure if I should be doing it with every kid.
Yeah, it's a really good question because obviously you're going to get a feeling if it really is needed or not. I've probably gotten to a point where I do it on every kid. In case I'm missing something, just hand on heart, knowing I haven't missed a really decent connective tissue disorder. It just means that I know I've eliminated everything. So if we have a look at the Baton score, and has that come up or do I need to change the screen?
Yep.
So you have so many resources out there. It changes all the time. And at the national conference the other week, I sat in on the hypermobility lecture and I was so lost. Oh my God. Sometimes when they present on a lot of the medical professionals, that obviously this is their bread and butter, it's just confusing because there's so many categories. But generally speaking, what we need to do is get through, I'll just go back to here, the Baton scale, which is actually on here. So I'm just going to click in. Now, this website, Ehlers-Danlos Society, if you haven't looked on here before, get involved. It's a really easy to use website, has everything you pretty much need to know. So the reason we are doing the Baton scale is because we want to know if we are ruling in or out the possibility of Ehlers-Danlos, which needs to be known, especially if you might be the first practitioner that has an inkling that this might be the case, or a decent hypermobility syndrome. So because this is such a confusing area, to be quite honest, I think it would be well within your wheelhouse to be referring back to a resource like this. But if we talk about Ehlers-Danlos in particular as a syndrome, there are, if I scroll down, there are actually 13 types. And well, I'm not sure any one of us is going to remember all the types and all the particular specifics about it. But if we have a look at what that means for us as a podiatrist and why it might be of interest to us, you'll see a lot of the symptoms fall into our wheelhouse, a lot of the pathologies that are occurring. Clubfoot, congenital hip dysplasia. After it's been treated, we're usually dealing with it later on. Low muscle tone, this fragile skin that falls in our wheelhouse, and some really different scarring that might be occurring on the feet or the lower legs. And obviously joint hypermobility falls within our wheelhouse. So you may be involved in the interdisciplinary management of someone with Ehlers-Danlos, or you're starting to see some of these things going on for your child as well. If we go back one and head into our hypermobility syndrome area, I think this is really important to remember, and I cover this in my subjective history if I'm starting to hear some of the symptoms or suspect some. It can be an awkward topic to bring up, but sometimes you just know when it's right to be querying. Hypermobility doesn't just affect where we're looking at the feet and lower legs. It's a whole system problem. So a lot of these kids are really late to toilet train. These are some of the kids that are still at school wetting their pants because it is about that connective tissue and the muscle control, and they do have laxity in and around the bladder. So bowel accidents, bladder accidents can be some of the history you might be hearing about. It's not just about being so flexible that it's fun as a party trick. It's actually causing these children some big problems, especially in school. Biggest risk is obviously dislocations. So whether they relocate or don't relocate on their own, but they often talk about jumping on the trampoline and their knee or something clunked out and clunked back in again. That's quite a common symptom you'll hear about. Just really good at doing inversion ankle sprains a lot. They can kind of walk them off a lot of the time, but not always walk them off. So hypermobility is something you'll hear a lot in your clinic. And when we're actually doing the assessment, which I think we've got here, is this test, which we've all learned and we've all done before. So it is a score out of 9. And we are looking at the fingers, and it has to be the finger, the fifth, going back beyond 90 degrees. our thumb heading back towards our arm, obviously, both knees hyperextending in stance, elbows overextending and being able to touch the floor. Obviously, this is not diagnostic. It is just a screening assessment. So if they score really high on here, so 6 out of 9 or above, plus you start hearing some of those symptoms, dislocations, maybe some trophic scarring, really extensible skin. There's a whole heap of different symptoms. You might start to get a little bit suspicious that there could be a hypermobility syndrome, which will be something we'll talk about in our referrals. So if we duck back one, we touched on it a little bit earlier, but I think I often forget this sometimes, depending on the age of the child. Our neurological testing is super important. So don't forget to get out your reflex hammer at the very least. So checking our typical reflexes that we check, but also when you're doing your muscle strength and muscle range, that you're feeling for any catches or clonus that might be occurring as the main things that we're looking for. Just moving a little slightly faster, heel raise test. So when children rise up onto their toes, and this is something that I get them to do during gait, I'll get them to walk on their toes all the way down to one end. What are we testing when we're doing this or looking for?
Calf strength.
Absolutely. So it's like a strength fatigue type activity.
The arch develops when they're raised.
Too good. Too good. Was that Nigel? So the biggest thing that I'm looking for is it's a quick determinant of whether they have flexible or rigid flat foot. Because obviously if they rise up onto the ball of their foot and no arch appears, it could be a sign that I need to now go test and see if there's any rigidity through the foot, tarsal coalitions, etc., or it's a rigid flat foot. It's coordination, it's strength, it's a bit of a fatigue test, and it's also helping me screen for any rigidity. Single leg stance timed. If you haven't been doing that, I would implore you to put it into your assessment because it's so quick to do. Kids love it, especially if you use an iPad with a big timer or they get the phone out and time how long they're doing a single leg stance. Super quick. We know what the norms are, and it's a really good pre and post treatment score for you to be using with patients and to show the parents how improved they are now that they've got their orthotics in, for instance, or correct footwear. And look how much more balanced they are. 2-minute walk test. Is anyone using the 2-minute walk test? The physio's using it in your clinic?
Oh, no.
So 2-minute walk test, it started with the 6-minute walk test, but that takes longer. So then there's a lot of evidence now on using a 2-minute walk test. You'll see this a lot in the OT and the physio space, and I think we need to get better at using it as pods. So when you start looking at the research into the 2-minute walk test, it's been conducted in a lot of pathological populations. So COPD, so that respiratory testing, you've got your CP, so that cerebral palsy population, seeing what their kind of walking capacity is. But it's such a simple test. It only takes 2 minutes with a bit of setup time, so maybe 5 minutes total. And it's another really good pre and post outcome measure that you can be using to show how well they're performing now you've instigated whatever particular management that you have. So might be some homework for you all. If you have a look up the 2-minute walk test in your own time, you'll see that there's really strict guidelines on how to set up the space because it needs to be a continuous walking between the two distances. And what you actually measure is how far they've walked in 2 minutes. So from A to B, you know the measurement and you know how many laps they've done and where they've stopped. And that is the 2-minute walk test. Super easy to do. We've definitely started putting that into our undergraduate teaching, so all students are coming out doing it. It's just a really easy test. And the last one that I've just popped on here for you guys to think about is the movement ABC. Has anyone seen the movement ABC test? Not so much yet?
No.
All right, so I reckon this would be I think this has become far more important for us to be involved in, particularly since obviously with NDIS. So if you're seeing any or a lot of NDIS children who have NDIS support, the movement ABC could be something that you instigate in your clinic. And because you've got physios there, it would be really great if the two of you are doing it together. So the movement AB, it used to be movement ABC2, now there's the third version. It actually comes as a kit. So there is a little bit of an investment on behalf of the clinic. It comes in, literally, it looks like, if they got a picture here, it comes in, just give you a quick little image when you want to go research. There you go. It comes like, there's the bot. Oh, it's so similar. It basically looks like this. So you get like this little suitcase with wheels, and inside the suitcase are your assessment booklets, all the tools that you need to complete each task. And it's a series of fine motor skills and gross motor skills that are valid and reliable and all have normative data for. And you run the child through each of the tests depending on their age group. And then you produce a report at the end, which puts them into a traffic light system, green, orange, and red. And it's definitely the way that if you receive a report from a paediatric physio, they probably will mention the movement ABC and what band they're in. OTs use it routinely. And now we have definitely instigated this into our undergraduate teaching so that all students can come out doing a movement ABC. So if you haven't had much to do with the movement ABC, it could be something really good to invest into your clinic. It's just a really good overall measure of where a child's at pre and post treatment. So movement ABC, you might start reading a little bit more about. But of course, if we flick back to where we're up to, and I'll just share again. Where have I gone? Back here. So sorry. Let's just quickly share the Word doc. When it comes to objective measures, we have all of the measures prescribed within the Gallup. The ones I've given you are probably just above and beyond or extras. These are really good to do, and maybe Anthony will do these with you in person to make sure everyone's feeling really confident, all these. But there you can see your Baton score. We're going to just quickly talk on this. And you do have this collection at the end here that are just biomechanical assessments that you may or may not do as well. So
right. I'll just say some people may have patients. If you don't have a patient, you can stick around. Otherwise, keep talking.
I'll just do the last bit. Be on recording.
We can always just share people the remainder bit. So absolutely.
Easy.
Thank you.
Sorry, guys. All right, so if I jump back here quickly, because the one last thing that we just want to talk about is where are we at with traffic light, because I know that was one of your questions. So if we move forward here and just have a quick look at where we're at with the traffic light system. So the way that we're teaching it now, and depends on your team as to where they were in their cohort, we still talk about the traffic light system, which is our pediatric flat foot performer. But we've now engaged as well. We've got talking about the FBI 6, obviously, and the Ready Recna. So if we move forward, what are these resources? So this is what we might have been more familiar with. So the pediatric flat foot performer, we still use this. I think it's a bit of a poor form in the way that it's structured. I still use it in clinic, but I think with this, honestly, use it in a way that works for you, because it can be really helpful in you working out your treatment pathway. Am I treating this kid or aren't I? You know, those kids that you're just not sure, you're sitting on the fence a bit. I think if you take yourself through this, it'll give you a bit of a clearer idea of where you're coming out at the end. So we still get students to do this. We want to know about, do they have a strong family history of painful or problematic flat feet? Are there any other associations, diagnoses that they have? Symptoms, yes or no? Has there been any traumatic incident? Are their activity levels being affected? Do they have any hypermobility or other system review going on, and any previous treatment? So I think if you're getting a lot of ticks, yes, 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 up here, it does start to lead us down to a bit more of a treat. I mean, the absolute go ahead and treat is if there's symptoms. If someone's in pain, we're going to treat.
Yeah.
I think that's the no-brainer, obviously. You can use these if you like, but it's also nice just to keep your mind around this. I think every now and then we need a reminder if we're seeing, is it definitely a typical flexible flat foot, or are we starting to creep into some rigidity or something a little bit strange like a skew foot for referral? So I think it's good just to have them there on the sheet just to prompt your mind, really. But once you've gone up here, and this is where I think the form is really poor, you've got your observations down here, but here's where you're making your diagnosis. So I feel like if I had my way, I would put this table up and bring this down, if that makes sense, because this is where you're starting to decide what type of foot it is. So you've got a typical flexible flat foot. It's symptomatic. Go ahead and treat. It's asymptomatic, but it's structural deformity that's getting worse with age. Monitor/treat, in my opinion. Or it's asymptomatic and it's completely developmental. It's age for stage. We're going to leave you well alone, and I'm probably always going to give you footwear education. So that's how you can use this to help with your clinical reasoning as to when you won't treat. And I think this can be really nice, even if you have it printed out on the desk and you're doing some ticking and flicking. It's really easy for a parent to understand when they start to see the traffic light. Now, obviously, we've probably moved on from some of these measures. So RCSP, we're probably using less and less. There's not such great normative data on navicular height to be able to reference that, but you can use these if you want to. So good for your clinical reasoning, but what are we doing now? We're basically using the FPI-6, the Foot Posture Index, and we're placing it within this Ready Reckoner, which has come out from Angela quite a few years ago now. It's been out for a while. And the thing that I think we need to keep in mind here was that all of this data was pulled from other studies. So they went and found a whole heap of FPI-6 data on children, and they pulled it in together and put them in their age groups. So if you have a look at the first line here, this is a three-year-olds. If you cruise along here, you can see that it only came from 21 pieces of data. So it's not as helpful. Nonetheless, that's what was available. 4-year-olds, 20 pieces of data. But if we cruise down to the middle here, you can see that we've got 9, 10-year-olds with larger data sets. So the idea of this is that you do your FBI-6, you get your number, and you pop it in here. So if you had a 10-year-old who had an FBI-6 of 10, you can see that they start to fall outside of the 2 standard deviations. And the idea behind this would be that that would be an indication that you could go ahead and treat. Where if they're sitting in this 0, so quite a vertical looking foot posture through to a +6, so slightly pronated, that they're still within that normal range of a typically developing foot, and you would leave well alone, or you would monitor and do footwear education. So this is utilizing this concept of the bell curve. So we know that all measurements fall if we pop them within a bell curve. The people that we're really worried about, or the things that we're worried about, are these guys down here that fall outside the typical ranges. So beyond that 2 standard deviations, you could hand on heart say, I need to treat these kids. If they're falling and 68% of their peers are all about the same, you're probably monitoring and giving some other treatments. Starting to get towards this yellow area, that's still, once again, that traffic light concept. You might be monitoring, doing footwear education, maybe some exercise progressions, but you might not be jumping to orthoses straight away. So this is what we use when we're teaching now to guide whether we treat or we don't treat from an evidence perspective.
Yep.
So the Ready Reckoner, you can grab it online. It's super easy just to print one off, like literally just have it on your desk or wherever people want to access it from, so that when they've done their FBI-6, they can jump in there and think, oh, actually, for a 4-year-old, they're bang on where they should be, or actually, no, they're way off. And I know it's a simplistic way of saying, because we've taken subjective history, we've done objective, we've got our clinical knowledge as to whether we think this is a problematic foot or not, but the Ready Reckoner will give you just that little bit of peace of mind that you are treating within a way that it is evidence-based. Do you guys use currently the FBI 6 around the clinic at all?
Yeah, a little bit as a sort of a guide, but I'd probably say like most of the time we're probably really symptom focused and then we might introduce like okay, you, let's start looking at things like the FPI 6.
So I think this becomes more probably because I saw a huge proponent of peds that are just coming in for foot checks because they knew that I did peds, so they come in, are their feet normal?
Yeah.
So they're not always symptomatic, and you're like, oh, do I treat or not treat these feet symptoms? Go your hardest. It's just that other area can be really quite handy for you. And then other than that, the only area I was going to lead on to was just some of our referrals, which I was going to spitball with the group once again, because I think like with a lot of things in peds, you actually know it. It's just a matter of remembering it or thinking about it again. So some of our referral pathways become easy because if there are symptoms or pathologies that sit outside our scope of practice, then we're referring those. If we're getting things like night pain and rest pain, we're starting to have our antennas tweaked that this could be a bone pathology leading towards tumors and nasty things. So we're always going to refer those. But yeah, I'm happy to do that another time. We can specifically look at certain pathologies and how we deal with them or how we refer them. But yeah, I think that was all for today, really, to cover around that subjective, objective, and making sure you're covering all your bases. But it sounds like you're all doing a good job because you've got it set in your Clinico. Is it Clinico?
Yeah. I think that seems to be the thing is that reminder of how important that assessment is, that it's, I guess, effectively standardized so that from one practitioner to another, you're just not letting stuff slip through the cracks. And you can then, 2 years down the track, check it again. So yeah, I think for us, it's just probably we've got it there, but it's how well is it being used, and also how well are people aware of what all of those things you went through, what's normal and when, and exactly like what involves like a Baton scale and all those things.
So when you have Anthony, it would be really good for him to probably, because I think sometimes it's really good to see how someone goes about delivering said questions, because there's a bit of a, not an art, we've all got our way of doing it, but there's a nice way using the Gallup that it all kind of connects, and you'll see him follow through the threads of about the hip or about NICU, etc. Because it's more, as you said, it's that further questioning, where to go with it and what does that mean. But yeah, if you're using the Gallup, I think you can hand on heart say I've checked everything. Because I think I believe what makes people nervous when seeing children is that we don't want to stuff a child up. And we don't want to get something wrong or miss something. Like the thought of missing like a really nasty pathology would be heartbreaking. So I think if you're using the Gallup, you less chances of missing something because it's really hit somewhere across every part of the body. It would be hard to miss something if you've used that as your base.
Yeah, no, that's good. No, that's great.
Oh.
Thank you so much.
Oh, good.
See ya.
Thanks, Matilda.
Yeah, so yeah, I'd love to sort of touch base again, because this is something that I think is probably worth almost doing semi-regularly with team and potentially new team members, because I think it's something that I know I came out with really confident out of uni, but it's something that probably has sort of slid without doing as much PD on it. So
yeah, it just happens. The more you practice, obviously, and the more familiar it is. Yeah, if you ever, look, honestly, I can always get to Melbourne as well. Some of these things I think are good in person, as you know, and you'll have Anthony there, which will be awesome because you can actually demonstrate assessments and guide people as to how to do certain things if it's not being done quite. But awesome. I hope it was useful.
Very useful. Thanks, Hayley.
Awesome.
Thank you so much again. And anything,
easy.
That'll be great. Cheers.
Yeah, awesome. Thanks.
No
bye.
worries. Have a great day. Good luck with the move.
Yeah, thanks.
Ciao.